trying to, compile all the tests and then telling the interpretation of that. So I think at the end, of this session, so whoever wants to have some opinion or want to share their cases, they can briefly summarize in one or two lines so that the experts are here, they can just share their experience in treating those patients. Thank you. Over to you, madam.
Thank you. So good afternoon all. I totally understand it has been a really good day, and of course it's a Sunday and post lunch. I can understand. So if you want to sleep, definitely I'll make it a point to wake you up, because it's going to be an interactive session. I'm going to ask questions mainly because I'm not going to say anything new. Everything is discussed. I'm just going to put it in a systematic way so that you wouldn't miss anything. That's all it is. So coming to the interpretation of immunological results, we have discussed very much in detail, and my previous presenters very elaborately, every single essay has been criticized, and the positive and the negative things about it has been discussed, and so it has made my life really easy actually. So now we just need to know, obviously when we are kind of interpreting the immunological results, there is a lot more to it than just the positive and the negative. So we should be always ready for challenges, because we never know from which angle it strikes, either it's from the patient side or from the donor side. So with this background, I would like to touch upon the various factors which definitely need to be considered while reporting. So there is a the list of the many factors. As you can see, it's a big list, and I know it is too much work and too many things. So is there a way out? Absolutely no. Then let's compromise and let's see how we can deliver a best the outcome to the patient. So this is only through the systematic approach. We cannot skip anything. Every factor which has an impact needs to be considered. There is no way of just ignoring any factors here. So let's begin with history and the timing of the test. Is it really important? Okay, so let's discuss a case here. 45-year-old female with CKD working for the first living donor transplant. Donor being father, and my CDC is weekly positive, and Dr. Hunter's flow cytometry is negative, and HLA screening was negative. So what do we do now? So can we ignore and go ahead, considering there is a good chance of false positivity? Do we need to investigate further? So who want to volunteer? What are the possibilities? The last benchers? This is an extended CDC. So what's next?
DTT.
Fantastic. And only DTT? Here we go. So we did the auto CDC cross match, and that was negative. So why do we have to do the CD auto? Because auto antibodies not only reacts with the auto cells but also with the allergenic. So it's very important to differentiate whether it's an auto antibody or an allo antibody. Again, if it is a positive CDC, then we need to know whether it is because of IgM, that's also complement activating, whether it is an IgG. So when we treat it with DTT, like we discussed in the morning, the DTT inactivates the IgM by breaking the disulfide bond. So what is left behind is IgG. So what is this? This is an allo IgM antibody. So the question is it of significance in transplant? Yes, no, or what do you want to do? I'm sorry? Fantastic. So the question at this stage was, this was a reference sample which was referred to us. As all of you know, the test request form history is not properly mentioned. So we wanted to know why this patient has developed allo IgM. Is there a sensitizing event? Is there something we are missing? So the patient had a history of blood transfusion week ago. That was a sensitizing event, and that is the reason the patient has developed an IgM. So let's quickly look at the importance of history here. So it's already been discussed, pregnancy, blood transfusion, transplantations are the really, the highly risky sensitizing events, and this causes immunological priming. So does that mean only the patients who has these sensitizing events needs to be screened and checked? No. We also know that even without the absence of obvious priming event, the patients can develop antibodies. It might be because of the cross reactivity to the microorganisms or vaccination and so on. So it becomes imperative that every patient you are taking for the transplant, antibody screening is a must. So this is one of my favorite diagram, and our first speaker beautifully explained the immune responses. So I'm just going to kind of now show you which status, which time of the his immune response we did this test. As we can see, the cursor is coming, I guess. Okay, where did this go? Okay, so this is the place. There is an antigen stimulus has taken place. And as you can see, there is a lag phase or an inductive phase where the T cells are proliferating, B cells are proliferating, and antibodies are not started forming again. That is the time, if you do the test, you will miss it. The sensitizing event, you will miss it because the antibodies are not formed. So, in this patient, so probably we have done the test somewhere here. So where the IgM is started just developing and IgG is not formed. So that is the reason we have picked up the IgM, allogenic IgM, not the IgG. So what would have happened if we had kind of tested, they've done the antibody screening or a cross match after the 2 weeks of sensitizing event. So probably we could have picked up this antibody from the antibody screening itself. So once there is a sensitizing event, the minimum of 2 weeks is needed for the IgM to start coming up. One more most important thing I want to kind of mention here is, as you can see, the IgM is the first one to come, and then it's a small peak, and then it kind of goes down. And then there is an isotype switch, and the IgG comes up, and if you see, after the months and years, this also goes down. So there is a negative phase, where you cannot identify any antibodies at all. Like Dr. Shruti mentioned in the past, the history and the past is also very, very important. So coming to the risk of alloimmunization, this was discussed in the morning. So what is the risk of alloimmunization after the sensitizing event? So in the era of where the blood cells are not leukodepleted and there was an increasing blood transfusion was given, then the risk was as high as 50%. However, now in the era of 100% leukoreduction, which was followed in many of the hospitals, the risk has come down drastically, because even though it is not completely leukodepletion, it is significant reduction of leukocytes which we are introducing with the red cells. So this has come down to 5%. The pregnancy we still kind of see because of the introduction of fetal cells into the maternal serum. The antibodies can be developed against the paternal antigens. So 25 to 30% of the patients, pregnant ladies might develop HLA antibodies. Especially after 2 or 3 pregnancy, the risk increases much further. What is the single most important risk of alloimmunization is the post-transplant rejection. The studies have clearly shown around 60 to 70% of them have donor-specific antibodies or anti-HLA antibodies, even if they are not donor-specific. So if you are thinking for a second transplant, then obviously you definitely need to know what this patient had developed in the past or exposed in the past. So coming to the frequency of timing, is it important? Yes, the timing we realize it is very important. We need to know the sensitizing event. We need to know how much gap we have to give. We need to know when to do it. So what are the, throughout the world, what is the guidelines or what is the recommendations? So what they say is, if the patient is on the transplant list, antibody screening is a must for every 3 months. Unless the patient was sensitized, there is a sensitizing event in the form of blood transfusion, infection or vaccination, etc., then you have to do the antibody screening after 2 weeks to see whether there is any new antibody has developed. However, nephrologists can say every 3 months antibody screening is too much to ask for. So Some centers in India, they've kind of, made it into 4 to 6 months. So it entirely depends on where on the transplant list is your patient is on. Again, post-transplant monitoring, we need to have, the guidelines says every 6 to 1 year, post-transplant monitoring is done, has to be in the standard patients, standard risk patients, and the high risk patients. Definitely there has to be consensus between the nephrologist and the HLA lab. So let's move on to the historical reports. Does this really important? Is it out of sight is out of mind? Is it as simple as that? Not really. So let's look at the second case. 36-year-old male with pre-transplant workup for second transplant. First transplant lasted for 5 years. He managed to push it for another 5 years, and now he wants to do a second transplant. What we have information is CDC cross-match was negative. That is the reason we went ahead and had the transplant. So the test results of all the assays is shown here. So anyone wants to know any more information? I think we should finish the talk faster. So come on, interactive. Anything? Any information or any test we need to know? So what happened with this patient? So post-transplant, we went ahead, post-transplant, third day, patient developed graft dysfunction. So when we repeated the cross-match and screening at this stage, just 3 days after the transplant, the patient was positive in all the assays. That is, cross-match was strongly positive, flow cytometry cross-match was positive, antibody screening was class 1 was positive. And when we did the single antigen bead assay, the HLA got A2402, that was a donor-specific antibody, causing the rejection. So the question now is, why this patient was negative pre-transplant, and why this patient had a graft function normal in the first 2 days? Why the dysfunction has happened on the third day? Can anybody explain? Sorry? Fantastic. So going back to my favorite diagram. So the negative phase, that is where we did the test, and we didn't have any information about the previous sensitizing event. So like Dr. Gashruti and others said, the antibodies wax and wane. Important is even the 10 years before the patient is exposed to something, it is relevant today. So it is very, very important that, even the patient transplant has failed, but you need to know what were the antibodies which causative agents. Okay? So what happens on the reintroduction of the same antigen? There is an accelerated immune response, that is the IgG titer goes above 1000 within first 24 hours. And the antigenic stimulation is, what you need is 1/100th of what you needed for the primary stimulation. And also the IgM quantity is very high, and IgG is very high. So if the graft which was functioning first 1 or 2 days, and the third day it just kind of causes a rejection. So what do you call for this kind of rejection? It's called accelerated rejection. So what happens? Already, as you guys said, this is a prime. The donor, a patient is already primed for the specific antigen. When you are reintroduced, there is an amnesic response and prime secondary response causing the rejection within 3 days. So coming to the, sorry.
How to prevent that situation?
And we are doing another
How to-
3 months.
I'm sorry?
Should we screen for TR?
I was just answering him. He says that how you could have prevented this.
The
Then we're
only-
doing it another test after 3 months before doing it.
No. Sir, you are following up the case which is already got the kidney has rejected.
No.
If we are transplanting that same patient,
Correct.
everything is negative, what should we do?
So basically that's what I'm trying to say. The historic results are very much important. See, when you are in a negative phase, there is no way you are going to pick up the antibody. There is no way you are going to test which memory cells are there. So that's why it is very important when you do the transplant, you need to know what antigens you are introducing to that patient. So, and also, like, once there's a rejection, then many of the times it's like, your kidney is rejected by. But nowadays, many patients are going for a second transplant, third transplant, and so on. So, when there is an antibody mediated rejection, or if the patient has developed donor specific antibody or any antibody, that has to be documented in there. I'm sorry.
In the context of not knowing what the primary donor's HLA typing is, could you get that information from a kidney biopsy?
Kidney biopsy of?
The previous kidney transplanted kidney.
See, that's a tricky question. See, you need lymphocytes for the HLA matching.
No, but you get HLA from any cell.
It's actually being done in India.
No, but
Okay.
There are certain labs are now using NGS,
That's what I'm
getting the
asking, sir.
biopsy, getting the elevation.
Getting true.
Then they are trying
Then at least you can establish the
it's being
previous.
done.
That you can do
I guess-
cell-free DNA test to
Cell-free DNA, see, as long as the kidney, which is, if there is a rejection, if it is not shrunk and completely gone, I think if you are kind of able to get some cells, probably yes. But if this is the case where the second transplant has come after 5 years of first transplant failed.
So I think there's no sort of test that would make this immunological memory come to the front.
True.
Unless you actually.
True. It's all about maintaining the good documentation, what you are introducing, at what point, what antibody they have kind of developed, even if it is not donor specific at that time.
I guess one.
do you think that if you would have repeated another antibody panel test before doing the second transplant within a gap of a month or so, it
So
would
this
have,
is
would
the-
have prevented?
No. All the workup was done within the 1 month of transplant.
No, I'm not saying that. I'm
Huh?
saying that if you give a gap of 2 to 3 months, I mean, you document 2 tests.
See, until unless you introduce that same antigen, you're not going to produce this antibody which is specific to that antigen.
Yeah, so it could not
Ah.
have been
There's
prevented.
no way to
So, until unless you know which were the ones which are not acceptable antigens. So I'm sorry.
I'm sorry. Please.
Go on.
Is there any way of stimulating these B cells in vitro, whereby you can expose the donor, the prospective donor antigen to the B cells, the recipient, and in vitro stimulate them to see if they produce antibodies or not?
I-
This is all theoretical, I guess.
Actually, doctor, you're right. This kind of tests are in the process of development, where you find out the memory cells. Sorry. So there are some sort of tests in the process of development.
Experimental test.
Experimental phase.
Yes.
I just read some in the paper.
True, I am also.
Yes. So you find out the memory cells and find out what kind of memory they have. So these are the tests but in this particular case, single antigen tests have not been done, only cross match. Maybe if
Single antigen bead test was done and the antibody screening was already negative. Since it is a high risk patient, we did actually kind of did and it was negative because retrospectively the same sample we did it was negative. So I guess
Specific singular, all the,
I'm sorry.
you should have done the whole specific SABs, I mean for each singular. You did a PRA SAB.
PR screen. I somehow I kind of want to say the HLA screening than a PRA because these two are different. So when we did the screening, it is negative. Normally, it is when the screening is positive, we go ahead and identify the single antigen base and which antibody.
since it's a
Ah.
second transplant,
Exactly. See, the role of single antigen bead assay in the negative, negative screening is kind of quite a little bit controversial because the beads which coverage for the antigen in screening is much more than the SAB to begin with. So, however, considering there was a rejection, we retrospectively went and did, and SAB was negative. So I think probably we have to rely on the memory cells, some experimental thing or documentation from the beginning is a must. Okay, so shall we move on to the couple of other factors? So which test platform and what are the advantages and disadvantages of that platform? You should know when you are reporting the test. So we already discussed in detail about this. So I'm not going to go in detail about the every platform and what is the pros and cons. Just we will discuss with the case base whatever it is required. So 54-year-old male patient with end-stage renal disease working for ABO incompatible living donor transplant, donor being his sister. No prior sensitizing event. Pre-transplant workup done 30 days ago was negative, and 2 days before the transplant, which is all shown below. So as you can see, CDC became weak positive. Flow cytometry on B cross-match was positive. However, antibody screening is negative. So how do we do? How do we go further? Sorry? Fantastic. Plasmapheresis should not cause until unless you are giving a lot of plasma for the rituximab. Okay. Yes, absolutely. So just we need to know when the what I'm trying to say is writing a proper history really saves lot of time, unnecessary hassle and postponement of the transplantation. See, we didn't know, then we have to call up and get the history, and meanwhile we kind of assume why, because this is again a referral sample, since it is a ABO incompatible, the conditioning as a rituximab was given. So how do we overcome this? With the help of pronase treatment of the lymphocytes. So what does this do? The pronase is a proteolytic enzyme which cleaves the Fc receptors which are expressed on the B cell. So this not only decreases the non-specificity, on a higher concentration it also takes off the CD20, where the monoclonal antibody rituximab binds to CD20. So that is how we overcome rituximab for induced false positivity. So we discussed this. Okay, coming to case 4. This is the patient who had undergone renal transplant in 2003 and now having suspected chronic rejection in April 2021. So good 17-18 years the kidney has worked, and that's amazingly well. So cross-match, CDC cross-match was negative and flow cross-match was negative, and HLA antibody screening both class 1 and class 2 is positive. So how do we interpret these results? So can we consider HLA antibody screening is false positive, or should we say the CDC and flow cytometry is false negative? Which one should we go for?
Dilute the cross-match serum.
Sorry?
Dilute the serum first.
Madam, I don't think you should say any answers now. Okay, thank you. Okay, so perfect. We have discussed about the prozone phenomenon, the importance of having the proper diluted lymphocytes, and also the importance of having the diluted serum in the CDC tray. If you are doing a CDC, you have to do it properly. There is no shortcuts allowed, because CDC being a manual assay, and which is really like, expertise is needed. Even with the experts, sometimes there can be a contamination, there can be a false positivity. So when you are sending for the CDC, cross-match, with the HLA lab, make sure that dilution is done. As per the ASHI manual, it has to be done. So that also means you should be sending to somebody reliable qualitative lab. And also, the flow cross-match also can follow the same principle, because too much of an antibody giving to the prozone effect and negative, false negative results. So on dilution by N/16, flow cross-match also came positive.
But CDC should have been positive in this case.
I'm sorry?
CDC should have been positive.
CDC is also positive with the dilution.
The previous slide which you showed.
That was with neat serum.
That was neat. That is the reason I wrote it actually. I was just waiting, except somebody else will look it up. So that's the reason I wrote it. It is only neat serum. So we discussed about the prozone phenomenon, and we will try to overcome with the post zone, that is antibody excess, by diluting the lymphocytes into 2 × 10⁶ per ml. So we discussed about the history, the importance of history, timing of the current test, and what is the historical reports and their relevance, and the advantages and disadvantages of each platforms. Coming to the HLA mismatch, again it's already been touched base, but just let's for the completion we will go through all the factors. So is it HLA mismatch or HLA matching is relevant in this era of the immunosuppression? And we also had a great talk about the immunomodulatory therapies and the immunomodulation by the stem cell transplant and so on. So is it really relevant? Yes, in spite of whatever the immunosuppression it's available, HLA matching definitely is relevant, and it is especially valuable if you want your patient to have a very long outcome for your kidneys, the transplanted kidneys. So if you want to reduce the HLA sensitization and also to improve the access to the retransplantation, definitely HLA matching has to be considered. So as you can see, as the number of mismatches increase, there is a decrease in the survival of the the graft. So the maximum, whatever the maximum the match you can do, it is beneficial for the patient. So what does throughout the other part of the world or other the world data says? So this is a very good study which is done by the Transplant Registry from Australia and New Zealand. So they did the survey on 12,000 plus recipients of kidney transplant. So they noted at the end of the study that each incremental increase of HLA mismatch was significantly associated with higher risk of graft failure and rejection. So we know that at this stage we don't have a choice. We are beggars or not choosers. Definitely it holds good for transplanters as well as for us. So whoever comes as a donor, we are just kind of transplant. I guess this is the time we think a little bit more broader, and probably something like the transplant registry and the donors list and the big patient list and swapping around kind of helps our patients in a big way.
Can I just say something?
Yeah, please.
This HLA mismatch is more relevant in the context of cadaveric kidney donation, and what it was shown was if it's in the context of a live donor kidney transplant.
See, if there is a live donor, at least haploidentical match will be there.
Not always if it's spousal.
Yeah, definitely.
Yeah.
Definitely.
What it was shown was in the live donor setup, only the mismatch that has a good, perfect, better prognosis is mismatch. After
Sorry,
that,
one second.
So in the context of live donor transplantation, I think it's just the 000 mismatch which confers better prognosis.
True.
And any other mismatch, they seem to just overlap the Kaplan-Meier curves. But this incremental increase in the HLA mismatch
mainly for the
is mainly for the cadaver.
Mainly for the
Yeah.
cadaver.
Thank you.
So this is the one more survey which was done done in various parts of one from the Europe and the other from I think America I think. So they also noted HLA B and DR mismatch was significantly associated with worse graft survival outcome, and the European Renal Best Practice Transplant Guidelines which recommends matching of ABDR at least whenever it is possible. So coming to the risk stratification. So when you are dealing with the patients who might need a renal transplant, I think it is very important to know where your patient stands. Which risk category? Is it a standard risk or an intermediate risk or a high risk? So how do we really assess this? So this is from the British Transplant Society based on whether the cross match is positive. Is it in the CDC or is in the flow cytometry? Is it IgM antibody or IgG antibody? And depending on the titer, the risk assessment is done. So if there is anyone with a high titer donor-specific antibody is there, and if it is the current sample is positive and it is a donor-specific antibody, they consider as high risk. And if there is no donor-specific antibody, this is considered as a standard risk. So based on this, they have also recommended pre-transplant sensitization, whether the immunosuppression has to be augmented and so on. Just for the simplicity, I kind of put it on the table. So high risk is when there is a high level of circulating DSA is there. The intermediate risk is DSA which is there but much lower level, and probably CDC is negative and flow cytometry is positive. And standard risk is absence of any donor directed sensitization or DSA. So it's also kind of, the stratification is also helps you in dealing with desensitization programs and also monitoring as well. So coming to the unacceptable mismatches, so let's start with one more case. 37-year-old male patient with chronic kidney disease underwent living donor renal transplant in 2018. So donor was wife. I don't know how many of you kind of noticed. So whenever there is a husband has a renal, the dysfunction, renal transplant is needed, wife is the first one to set in. But step in and kind of donate, but not vice versa. I don't know either it is my observation or it is everybody's observation.
Everywhere it is the same.
Welcome to the real world.
Okay, I guess we can have a debate on this. If Professor Swarnalata allows later.
Recently we did one, that's why you could remember.
It's well, let us accept that things are changing now. It was worse. It is still worse, but things are changing. Please go ahead.
Okay, so the first transplant was rejected, and then and so this patient came for the second transplant workup, and now this time the donor being the mother-in-law. Okay, here we go. The first is wife and second is mother-in-law. So, so the CTC.
Times are changing.
So you mean the mother-in-law also giving the kidneys? That's what you mean to say? Oh, fantastic. Well, by the way, disclaimer: I don't have any problem with my mother-in-law. So coming to the CDC cross-match, which was negative. Flow cross-match again negative. HLA antibody screening was negative. Single antigen beat SA negative. So anyone has an objection to go ahead with the transplant? HLA typing. Here we go. I knew you were going to ask. So coming to the recipient HLA typing, it's on the left side. The donor, first donor whose kidney was rejected after many years is the second donor one. Second donor is the mother-in-law, which is on the last. So please have a look and tell me whether we go ahead or not. I'm sorry? Aploid identical because mother and daughter. That's I think. Can we go ahead? Fantastic. That's what I wanted to hear. The unacceptable HLA antigens for the second transplant are the one which is already exposed to the patient. A2, B7, HLA DR beta 130. Because even though the patient had rejected the transplant after many years, and they is already sensitized with these antigens. So even though we might not able to identify the antibody at that stage, definitely there will be a memory cells. As you put the the kidney, second kidney, there can be a trigger for secondary immune response, can cause accelerated rejection, again probably on the third to fourth day.
It's still hypothetical, right?
Well, this is actually the case which has happened. I will just kind of discuss. So, I'm sorry.
In terms of the possibility of them.
See, and this, I totally agree, but mainly, we know this patient is already sensitized. Yes, and this is a good risk that the patient, since the transplant has failed, they might have developed a, the donor-specific antibody at that time against this, and now there is a memory cells. So yes, it is hypothetical, but directly puts this patient under the much higher risk than the other patients.
No, because the organ is inside, we don't have any primary and secondary immune response in these scenarios. How do we expect that after second transplant you get a secondary immune response?
I'm sorry.
Organ is already there in the body.
Not necessarily.
First organ. The first transplant, that organ is inside.
True.
So we expect that those antigens should be continuously, means the patient should be exposed to this antigen.
So when the organ is rejected and failed, do you really have the proper blood circulation and the immunological everything? I do not think so.
Right, ma'am. In those events, even if the patient is, let's say those antigens are not present, we can still go ahead for transplant because antibodies are not there. With the proper immunosuppression, probably we can still go ahead.
See, if you don't have a choice, you can.
But with children, mother will always be sensitized to her children because she'll be exposed to the husband's antigens in the children.
true. Not.
This is a different, Manisha.
No.
The question is the HLA. Are you going to accept?
See, what you are saying is. No. Actually, see.
Necessarily.
It is already sensitized, no? They cannot have autoantibodies.
No. What she is saying is pregnancy as being a sensitizing event. See,
No, this is not, mother is not giving.
no. She's just giving an example. No. I. So.
The antigen is transiting there is no longer
I think we discussed.
constantly being
Ma'am, just to answer that question, sorry I have to step in. So, just to answer that question, see, if you kind of see the studies, what is the risk of allo immunization following pregnancy? More than 2 or 3 pregnancy, only 25 to 30% of the ladies get immunized with a paternal or a husband antigen. But in this case, there's a patient who had direct allo immunization and the kidney is failed. Yes, I mean obviously this is a, see, it comes under the category of HLA mismatch or an unacceptable antigen. So we are not telling you cannot transplant at all. So like he said, it is a hypothetical risk and which is a much higher risk. So you need to consider the fact that before going ahead with the transplant, there is a good chance that there can be a memory cell which can cause the kidney function or their rejection. There is a good chance. So you want to take.
Sorry to interrupt. I think if you can understand pregnancy, I mean immunotolerance, you could have actually mastered the transplantation. So I think that's a different topic altogether. To understand the immune tolerance developed in pregnancy and applying that to organ transplantation. I think we'll proceed with the present presentation and we can discuss that later on.
But that's a valid point. See, Sharada, you will not go ahead with the transplant. Forget about the pregnancy. I was just raising that issue.
Yes.
But this case, will you go ahead or no?
See, I never said don't go ahead. Just if you're going, no.
Because antigen sharing is there.
I mean, see, this is not my guideline. The unacceptable mismatches from the British Transplant Society, I just put it up. So it is there. Okay? Because you have introduced, there is a memory cell, they automatically, if you want to consider your patient as a high risk and you want to give the immunosuppression, go ahead, please go ahead.
Proceed, otherwise we will not be able to finish this
Okay.
session. Okay,
So when we kind of say unacceptable mismatches, it means when there is a presence of donor-specific antibodies there or mismatch antigen on the previous failed transplant to which the specific antibody has not been demonstrated, particularly if there is an incomplete sample history. This is from the BTS. And immunological memory, even if there is no antibody currently defined, this has to be considered when you are risk stratifying the patient.
Yeah. Point taken, please go
This
ahead.
directly excludes the mother-in-law's
I mean, let her move the slide, please. Otherwise we will call you to the chair.
Why the
If you
mother-in-law
are
part
ready
becomes
to
a
sit here till 8 o'clock, I have no problem, we'll continue with the discussion. But I think,
Okay, so coming to the cross-reacting antibodies, Dr. Firoz beautifully kind of explained about the epitopes and then the epitope sharing. So definitely when we are kind of looking at the virtual cross-match and we are trying to do the virtual cross-match, the cross-reacting antigen group has to be considered. It is there in the various locus and so once you are kind of, I always not very good with numbers. In my HLA lab, I put it up the table so that whenever I do the virtual cross match, I make it a point to look it up so that I don't miss it. So this is the one more thing we need to keep in mind when you are kind of reporting the virtual cross match. So the last two ones are the association. This is the one more thing we need to keep in mind. So what exactly association? Let's see. So 32-year-old male CKD working patient working for the first living donor renal transplant. Donor being mother. History of blood transfusion is there in the past. So when we did the cross match and the screening and SAV, the cross matches were negative and screening and SAV was positive. So what was the antibodies which we identified? HLA DR beta 5, DR beta 5 and HLA DQ beta 1. So as on the right side of the table, as you can see, that is the recipient HLA, and I have highlighted the identical ones, and the antigens which we are going to introduce from a donor is 24 HLA A24 B7, HLA DR beta 150, DQ beta 16. So can we go ahead with this transplant? Is this patient, any other information needed in this patient? Can we? I think this is not controversial, at least everybody can say.
We can go. We can proceed for transplant.
Sorry, you want to finish first?
No worries, thank you. See, now the association comes into place. DR 51, 52, 53. So we know that it is linked to DR beta 1 genes, and there some antigens and some genes are associated and tend to inherit together. So we know that not only in the DR, one antigen is associated with the other, even with the DQ it is associated. See, we know that the donor had HLA-DR 15. So we also noted, if you kind of go back and see, the donor also had DR beta 106. So if you go back and see the association, the donor has DR 15 and DQ 6. So there is a good chance he also has DR 51. That is nothing but DR 5. So if you see the SAV results, there is already DR beta 5 with the high MFI of 12,443. So without doing the molecular typing of this, we cannot go ahead. Probably this may be the donor specific antibody. So this is also one of the things very, very important you need to consider before kind of saying go ahead with the transplant. So the last one is a very interesting case which happened in our hospital very recently. 43-year-old male with a history of 1 unit transfusion, 3/12 HLA match, and the wife being the donor again. So it was an ABO incompatible transplant, and we did the plasmapheresis, and AB titer was 1:2, and then transplant was done. So this was the pre-transplant workup, and CDC cross-match flow, HLA, everything was absolutely fine. And what happened? On day 3, the patient had acute rejection. It is an extent that the whole renal artery has thrombosed and the kidney had to be taken out within a week. So it is almost like, it has to take up because coagulability set in, and the patient, the general condition itself went very bad. So what's next? So we consider all the factors, whatever we went through the whole, and everything is negative. So even though screening is negative, like ma'am said, we did a screen, SAV twice, negative. Here we go. So we did a non-HLA antibody screen from the Immunological and from the ELISA platform, anti-endothelial and anti-thrombin 2 receptor 1 antibodies were positive, and anti-endothelial was positive, and also it is positive for PECR, that is paroxysmal trans-2-enol CoA reductase. So we know that from the last 1 to 2 decades, non-HLA antibodies, more and more cases are coming up, causing dysfunction and rejection. No, C4D can be positive in the non-HLA, and it is in the literature because I did say it is an antigen-antibody reaction which can. See, even though you say Uterica does not activate the complement, so I did look it up, and there are studies which kind of, looked, even if you kind of see the John Hopkins study, they did. I can show you the papers, no worries. See, this is an antigen-antibody reaction. Okay, I totally agree with Dr. Shruti to a certain extent that, some of the...
Sometimes the HLA antibodies may not come in the circulation. 50% of
Correct,
the time
correct.
we will not find it there because
But I totally agree with that. But can it cause it's almost like an hyperacute rejection within the 2 days. Can it cause without it is not coming into the circulation?
how do we know that endothelial antibodies are donor specific? Because I have come across this situation n number of times
I mean,
It's ABO incompatible.
see,
ABO incompatible.
but the titers were less than 1 and 2.
So C4 is a part of ABO.
Probably. See, probably.
That cannot be added.
No, it might be because of ABO
We
incompatibility.
get a wrong idea.
No, Dr. Shruti, it can be a part of ABO incompatibility.
The C4D can be part of
ABO incompatibility. So we are not really saying.
Medicine is not mathematics. If
Okay.
there are 1 or 2 points not being explained, please don't linger on wasting time for that. You go
Okay.
ahead to the next slide, please.
So
Medicine is not mathematics, okay? Or if there is
So-
some amount of C40, how does it harm? It can, you can have rejection. You can have a normally C40 positive without any evidence of rejection. You do biopsy in a normal creatinine,
Okay.
you can have
So
a
let's.
C40. Go ahead.
Thank you, sir. So see, I'm just trying to put up the whatever this is a real case which has happened in May. Whatever the reports and whatever the results, I'm putting here, and we are having a discussion. I'm not here to claim, or I'm not going to here
Can
say.
you have a next slide, madam?
So
The audience is there to ask the different other questions.
So we know that in spite of doing all the, considering all the factors, doing all the HLA, what I'm trying to say is we might still lose the graph because of various other factors. Probably we are still trying to learn. So with this, obviously I just wanted to know, when do we do this non-HLA antibody screening? Can we introduce into the real, normal day-to-day? So obviously it is the normal day-to-day case we cannot introduce. So this is a one John Hopkins study which we kind of really find it very interesting. They looked at who are the patients who had the transplant rejection or dysfunction because of non-HLA. So they risk stratified, saying that renal retransplanted, this is a second transplant patients and males who are less than 45-year-old and patients who had focal segmental granular sclerosis at the time of transplant were more likely to have positivity for anti-angiotensin II receptor 1 prior to the transplant, and also these might be higher risk of rejection because of this. So definitely I totally agree with everybody here. We need lot more investigation, many specific essays to say this is the culprit for this. However, there is lot of advancement, lot of the essays are coming. We need furthermore answers. So with this I would like to conclude. So just to kind of reinforce, every factor plays a role when it comes to kind of when you are immunologically reporting a results. So please consider this systematic approach is the key. So thank you.
Thank you, madam. That was a very practical approach, and we have covered most of the case scenarios or challenges we clinically come across. I think continuation of this, we can actually have the case, briefly presented by the candidates. You can just summarize, just take a mic and summarize so that we can continue the clinical discussion and finish up in another 10 minutes probably. And I request all the speakers to share their opinion or find out if they can find solutions. You don't have to present, you can just
Before
talk like this.
Sanala, can
Yes.
you ask her a question or two for the
Yes, please.
topic related? Because for a setup of a government hospital where we do not have all the facilities for a live transplant and for a disease donor transplant, what is your take-home message in a very brief word? Because ultimately people are waiting to understand that, So for a live transplant, I understand there are lots of history and things like that. So do you want, if you have a CDC negative, go for the transplant without any history of pregnancy or blood transfusion or anything, or you want at least CDC
and one solid assay. Sir, I think the history is the most easiest thing where there's a, if the coordination between the nephrologist and the lab people, we could definitely kind of, have a very good outcome. And second thing is, if the cadaveric situation,
we talk about life first.
Life first,
so,
okay.
So
you have plenty of time to work out, okay?
Yeah, in a solid assay,
okay,
we have only lysate DSA, which is useless.
Yes, correct.
So, sort of that, in particularly common setup, where we do not have other than the lysate DSA, what do you recommend?
Sir, you will have a screening at least? Antibody
I don't know,
screening?
Dr. Sonal, is it available?
HLA antibody
Names?
screening?
We are talking about solid facility of
No,
solid
no,
assay.
no, it's not available. It's not available.
You have a flow.
We have a flow, but we have
That's
not
not
tried
solid.
with the solid phase. What morning has been discussed, we only use the cell based only. Cell based is there, cell based is there. Flow is
And what about the disease donor?
Disease
No,
donor,
no, keep the
no.
mic to her.
Disease donor.
No, for her. Her question.
Disease donor in any case, even we do not, wait for the HAS or SAB and stuff like that. For a deceased donor, I don't know what happens in this world, especially in our country. They decide to give you organs only late in the night, and midnight you have to give the answer.
Let us not complain.
So-
See, let us not
so
complain.
anyway,
What,
no,
what,
no,
we
I'm
are
not
given
complaining.
If you complain, then we will not solve the
No, I'm
problem.
not complaining. I'm just telling you, considering the circumstances that we are placed in,
Yeah, we
the
all face that.
simplest way to handle it, what we have found in our center, is do a CDC, because there is a requirement of your Organ Transplant Act and it says clearly CDC, so you have no choice but to do it. And do a cell-based flow cytometric HLA cross match. That should give you an answer. If both are negative, I'll just go ahead with the transplant.
Right, because there is a lot of misconception here. Many people are only doing sort of lysate TSA and doing the disease donor, which I strongly oppose, but somehow I do not get support. So that's the reason I wanted to know from some of the experts.
So lysate DSA should be dead and buried. I do not feel it's a good test, number one. Number two, in a lysate DSA, you do not have C and DP and DQ capture antibodies. So you can do nothing. The test is inadequate.
Yeah, I wish you say it again and everybody here say.
So I
Thank you very
totally
much.
agree.
Thank you.
DQ now it can cause not only chronic rejection, even in the acute rejection as well in the very high titer. So Luminex crossmatch measures out many of the antigens. I think it is definitely
So sort
useless.
of any solid phase, good quality test, it is CDC as well as flow,
one solid.
cell-based flow, whatever we have.
Yes.
Go. So we are not doing any solid based that way.
That's okay. I mean,
If you don't have, that's the best you can do that.
Thank you very much. So.
There were many take-home messages from your talk, madam. Thank you so much. I think we have had enough
Thank you,
questions during
sir.
the session.
And we can always discuss.
No, I think the message has been, if you are given a choice of one all-encompassing test, that should be CDC.
Yes.
You have to agree with me. Single all-encompassing test, probably you'll have to agree that it has to be CDC.
Because old is gold.
Old is gold.